Podcast RX.
Podcast RX.
Podcast RX. Podcast RX.
Welcome to Podcast RX from Diamond Pharmacy, a show featuring the pharmacists and personnel behind the nation's largest correctional pharmacy provider. While we talk primarily about clinical and regulatory topics affecting the institutional healthcare clients we serve, we'll also occasionally get into the stories behind the people moving our company forward. This isn't just a pharmacy podcast, and you don't have to be a clinician or a pharmacist to enjoy it. On this episode, we welcome back Deborah Melito, Director of Clinical and Consultant Services for Diamond's Long-Term Care Division, to talk about the threat of Candida auris. Since first appearing in Japan in 2009, this drug-resistant fungus has showed up around the world and poses a threat to the sickest of the sick, especially in places like skilled nursing facilities. Deborah gives us a rundown on C. auris, why it's deadly, how it resists drugs, and what providers can do to protect patients. If you're not very familiar with C. auris, this podcast is an easy listening primer. Welcome to Podcast RX. I'm Adam Campbell.
Go.
Okay. All right. Well, it feels like you were just here. Dr. Deborah Melito, welcome back to Podcast RX. In these few weeks since we last talked to one another, any big changes or news to report?
Well, there always seems to be breaking news, but the moving van finally arrived yesterday from my son, who was relocating back to where we all live. He's been in Houston for 8.5 years, and we've patiently waited 3 weeks for the moving van to arrive.
Wow. Yeah, that must seem like an eternity when you're getting your son to come back home. So.
Oh, it did, and it's such a blessing to have him back.
Oh, wonderful. That's wonderful to hear. The last time that we got together, we were talking about recent CMS changes. And in the midst of that discussion, you made mention of the growing threat of Candida auris, which is a fungus that's been on the global medical community's radar for well over a decade, with the earliest known case in the United States in 2013. Despite its rarity, the CDC has called Candida auris, quote, an urgent antimicrobial resistance threat, end quote, and its invasive infections and propensity to cause outbreaks in healthcare facilities like hospitals and nursing homes has raised the alarm in the healthcare community. Deborah, nursing homes and antimicrobial stewardship, they're the twin pillars of your work as a consultant pharmacist, so I definitely wanted to get you back on here to explain exactly what makes Candida auris the threat that it is, and what long-term care pros can do to manage the threat. And I also want to note that this is a second podcast now where you've been asked to discuss Candida auris. The first was on the new LTC Pharmacy podcast, so shout out to them. And you also gave some recent presentations for ASCP, both in Gettysburg, Pennsylvania, and Chicago about this. And you have a presentation coming up for Diamond's educational conference in September, so you're really making the rounds on this. So thanks for taking the time here.
Yes, and Adam, it sort of all started with one of my colleagues from the Midwest area who's on the ASCP board with me and requested that, could I come and speak at the Midwest meeting about Candida auris. It really got me thinking and researching and learning as much as I could about that organism. And it's rearing its ugly head all across the United States. So, interestingly, in 2019, the CDC released their antibiotic resistance report. Now, we haven't had an updated one because of COVID. There has been a delay in getting us the new antibiotic resistance report. But in 2019, Candida auris showed up under urgent, which is the highest threat level, and it hadn't even been present prior to that. So it joins some of its other organisms, such as any carbapenem-resistant organism like Acinetobacter and Enterobacteriales. There are serious threat levels such as MRSA and VRE concerning, and then those on the watch list. So we do keep an eye on that antibiotic resistance report and, behave accordingly as far as that report goes. So that's really what put it on the radar. And like you mentioned, it showed up in the United States around 2013 to 16. We started to see it more and more in the United States. It was identified in Asia, and actually in Japan, in the ear of a patient, meaning, auris means ear in Latin.
Right.
It showed up in 2009 in Asia, and then it took about a decade to get to the United States.
Is it true that there were that it emerged in 4 different strains around the globe at the same time?
Yes, and those are called clades.
Mm-hmm.
So clades are like groups of organisms that feed off of, the main organism. And so East Asia,
Mm-hmm.
South Africa, those are some of the clades. And there's a 5th clade that's been identified, and it's in Iran.
Well, just to talk about Candida auris, or C. auris, as we'll refer to throughout the show, what makes it, why does it stand out from the other fungi in the Candida family?
Because we're very concerned that it acts like a bacteria and not a fungus.
Mm-hmm.
So it's very concerning to us that it's resistant to a lot of cleaning products. It's resistant to many medications. It can spread from person to person. It can spread from inanimate objects. So that's why we're very concerned about this particular type of Candida.
How is C. auris then so easily spread, and how does it stay alive in these different environments?
So if we're not using the proper cleaning product, which there are a couple products that you can refer to, there's a list from the CDC. There's the EPA listing. There's a K and a P listing. And EPA K products will work against C. difficile spores. So anything that works against C. difficile spores will work against Candida auris. And then the CDC came out with a list P that is for Candida auris. But we have to be very careful and educate our environmental service people that they can't think that because they see Candida on a label that it works for all Candida. It might work for Candida albicans, but it will not work for Candida auris. So having your environmental service people around the infection prevention and control table, as well as the quality assurance performance improvement table, getting everyone on the same page will be most effective.
When we're talking about symptoms of a C. auris infection, what does that look like? What do they look like?
So, Adam, this is really occurring in the sickest of the sick.
Mm-hmm.
So these are people that might be on a ventilator. They have not responded to antimicrobials. They have multi-drug resistant organisms besides Candida auris.
Mm-hmm.
And they still have a fever. So those are the people that you want to start thinking that there's something else going on, and it might be Candida auris.
Yeah. Can you tell me more about a little more about the most at-risk patients who are most vulnerable to the invasive and potentially deadly C. auris infection?
So those would be the patients that are of any age, by the way, that it can attack neonates, infants, clear up to seniors.
Mm-hmm.
Also, if you're a diabetic, that seems to be a contributing factor. And then again, if you're on a vent, or if you've had a long-term stay in a long-term acute care hospital or a ventilator skilled nursing facility, you seem to be more at risk for developing Candida auris.
And these risks are pretty steep because per the CDC, more than 1 in 3 patients with the invasive C. auris infection will die.
Yes, the mortality rate is very high.
To further complicate the battle against C. auris, I understand that it's not the easiest thing to diagnose. You spoke a little bit to that, but it's a complicated diagnosis involving testing. Can you tell me more about that and how you get the most accurate diagnosis?
Yes, so it all circles back to the identification from the lab standpoint. So you want to make sure that your lab has the capability of testing for Candida auris, and it's the MALDI-TOF TS system that needs to be in place, and that speciates to the Candida auris level. If you don't have that capability, then you can misidentify Candida auris to other types of Candida like Hemoloni or Candida Kawasaki. And then if you're not identifying it correctly, then you can't treat it correctly.
Another worrisome feature that makes CRS such a problem to combat is indefinite colonization, wherein patients infected may asymptomatically carry the fungus for indefinite periods of time. What can you tell me about this?
So that's persistent colonization that, you can find it on different areas of the body, such as the nares, of course, the ears. And then you can start looking at the oral cavity, the axilla, the inguinal folds, and even in the webbing of hands and feet. So we do want to swab patients or residents. If someone, their roommate contracts CRS, we could swab the roommate to see if they're persistently colonized. Unfortunately, we do not have a treatment for that, although chlorhexidine is being studied, but we don't know how many times you have to use chlorhexidine. We don't know how effective it is. So stay tuned for that.
And of course, the most noteworthy danger of CRS is, of course, the resistance to antifungal drugs and even some disinfectant agents. You talked about the ones that do work, but can you tell me more about just how stubborn CRS is in this regard to resistance, whether to antifungal drugs, cleaning products, etc.?
Well, let's talk about the antifungal medications first. So we have 3 classes of antifungals. We have the polyenes, like amphotericin B. We have other medications like the azoles, like fluconazole. And then we have the echinocandins, like micafungin. And luckily, the echinocandins are still effective, very effective against CRS. But the other 2 classes of medications we have found to be very resistant. So that's a worry, but we're glad that we can still use echinocandins. But we have seen pan resistance, meaning resistance to all 3 antifungal classes, which is very worrisome. We do have some agents that are investigational that are showing promise. They do work under different mechanisms of action. So we'll see how those turn out in the near future.
And just to add to what you were saying there, the CDC also notes that 90% of isolates are resistant to at least one antifungal and 30% are resistant to at least 2 antifungals. And then you mentioned the pan. Do you know any numbers on that?
Well, there haven't been that many organisms identified as pan resistance. There were several found in the New York area, but I don't have any other data to share.
Okay. What are the best then prescribing practices against CRS? What are the most effective infection control measures? You did speak a little bit to that, but is there anything more you can tell me in that area?
So the cleaning products are just so important, and also the way that we are caring for our residents that have CRS. So let's start with the nursing staff, what precautions they have to take. First of all, contact precautions, so wearing a gown and gloves before entering the room. Also, the way they're cleaning their hands. For CRS, we want to clean with alcohol-based hand sanitizer, only using soap and water if the hands are visibly dirty. And then we want to also use enhanced barrier precautions, which is something somewhat new from the CDC, that you're donning gloves and gowns for not just standard care, but for anything that you're doing, that you're touching the patient, whether you're changing briefs, linens, any type of cleaning, you need to use enhanced barrier precautions. And then as far as cleaning goes, we want to make sure that we're using the right product for the correct dwell time. And that's where surveyors will ask the environmental service people, do you know if that product works for CRS? And they need to speak to that. Mm-hmm. And then they're going to observe how that product is being used. Like, is it being on the inanimate object for 5 minutes? Is it 3 minutes? Whatever the label says.
With all this in mind, with the facilities that you're working with every day here, Diamond, what kinds of initiatives are you seeing then to really keep this threat in check?
Well, I think there are a couple things that need to be kept in mind. One, you want to be checking with your lab to see if they're able to speciate Candida auris. It's very important. They might have to send it out, but the send outs tend to take longer to get the information that you need. So I know for my nursing homes that I go to, I did check with the labs, and most of them do have the capability of identifying CRs. Then you want to educate your staff. And this is where I think listening to a podcast, attending a conference, listening to a webinar from the CDC, just being proactive about how to treat a CRS patient. So upon transfer, you do want to know anytime there's a multi-drug resistant organism that you're going to be dealing with. But in this case, today we're talking about CRS. So do we have enough alcohol-based hand sanitizer? Is that what nursing staff needs to know to use? Does environmental services staff know how to clean and which products they should use?
The most recent CDC data that I've seen shows just 33 clinical cases of CRS in our home state of Pennsylvania, and that's since 2018. Overall, we're still talking about a very rare organism it's not a threat to healthy people, as we discussed. But because your everyday work involves vulnerable people in vulnerable settings, Deborah, what's your personal outlook on the prevalence of CRS infections going forward? And where does CRS rank among the other threats posed by the drug-resistant organisms?
Well, because CDC has listed it as an urgent threat, I think we all will end up seeing it in some way in our facilities. I think it spreads very easily, but like you said, it doesn't affect healthy individuals. These are the sickest of the sick people. There are residents that have come from a long-term care acute hospital or maybe a ventilator bed facility, and now they're able to step down to a skilled nursing facility. So I think that if we have everything in place, how to clean, what kind of precautions to take, knowing the correct medications to choose, that's where your senior care consultant pharmacist can play a very large role in, hearing that it might be CRS, knowing that we should go straight to the echinocandins and bypass the azoles and the amphotericin Bs of this world.
Well, it's great to have people with your expertise out there getting ahead of this threat, certainly. And you mentioned you're going to be speaking about this at the upcoming Diamond Educational Conference on September 19th. You'll be giving a presentation devoted to CRS. Any other speaking engagements coming after that?
So I will be going to the National ASCP annual meeting, and I think I have a few speaking engagements there as president. So I think that's what I'm gearing up for at this point.
Excellent. Well, certainly wish you the best with all of that going forward. But Deborah, I do want to thank you again for taking the time to talk more about this very important issue. And I know that we've got some other things we need to discuss, so we'll be having you back on again pretty soon, I'm sure.
Thank you. My pleasure.
Podcast RX features conversations with healthcare professionals. The statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein. But we do hope you enjoyed them.
Podcast RX is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Keep up with our show on all the major podcast platforms, including Apple Podcasts and Spotify. New episodes usually drop the first full week of each month. Where possible, please rate and review the show to help us reach more listeners. If you have any questions or feedback for Podcast RX, we'd love to hear it. Shoot us an email at podcastrx@diamondpharmacy.com. We thank you again for listening.